Okay, this is going to be the Chapter 30 lecture on bleeding. Real quick, just a brief introduction. I know you'll see some stuff that says A before B except after C. This kind of goes back to our primary assessment for the National Registry, also in real-world application. We're going to focus first on circulation, not the airway or breathing concepts, given severe hemorrhage. Bleeding is obviously an extremely time-sensitive issue, and our goal is going to be to maintain perfusion. Just a quick way to sum it up is, given massive hemorrhage, the C of circulation takes priority over the airway and the breathing. You're not going to be able to save somebody or to adequately perfuse somebody by just maintaining an airway if they don't have any blood, any ability to exchange oxygen and carbon dioxide is basically what this is getting at. Briefly, anatomy and physiology. I know that we've already had a whole class over that, but just a brief touchdown on it, a quick little refresher. The cardiovascular system keeps blood flowing between the lungs and the peripheral tissues. Blood comes into your heart from the inferior and superior vena cava into the right atrium of the heart. Pumps it to the lungs, comes back to the heart on the left side, and then it is ejected out from there. Very easy concept. We're talking about a pump, fluid, and vessels. That's kind of what this is getting at. In the lungs, products of carbon dioxide, waste, they're exchanged at the capillary level for oxygen, return to the heart to be circulated out to the body. What this is getting at is if we run out of blood, okay, so we lose our fluid, if we lose the ability to pump the blood from the heart, or if our blood pressure drops and our peripheral capillaries dilate to the point where we're not able to keep enough blood in the larger container, so if our blood pressure drops enough, you can begin to go into early signs of shock, compensated, and then eventually decompensated shock. Okay, so like we were just saying, the three things that's required to maintain adequate perfusion is going to be our pump, which is our heart, our pipes, or are also called our containers, one way I kind of remember it, which is going to be our vessels, and then the actual blood, the actual fluid. So here's our first important concept we're dealing with. Here's our preload and our afterload. These are definitions that I think are pretty important to understand, not only literally what they say, but also the concept. So our preload is the amount of blood returned to the heart to be pumped out. And our afterload is going to be the pressure in the aorta against which the left ventricle must pump. Our blood pressure, extremely important. Our blood pressure is going to be our cardiac output times our PVR, which is going to be our peripheral vascular resistance. PVR is measured as a mean arterial pressure in a lot of different types of EMS systems, and also in a lot of different protocols nationally. Mean arterial pressure is kind of taking the, I guess you could say it's taking the place of a systolic blood pressure. It's kind of a higher standard of measuring perfusion is mean arterial pressure. So how you calculate a mean arterial pressure is you take your diastolic pressure and you add it to 1/3 of your pulse pressure. And quick refresher for your pulse pressure, it's simply the difference between the systolic and the diastolic blood pressure. So real quick way to do it out in the field, you take your systolic, take out your diastolic, and then you add it to 1/3 of whatever this answer was. That gives you your mean arterial pressure. A lot of life packs will automatically do it for you, life pack 15s. I'm not sure about other monitors, but mean arterial pressure is in your book. It's an extremely important concept to grasp as far as understanding cardiac output and also understanding adequate perfusion. Okay, just a real quick refresher on the cardiac output. It's just volume times rate. That's how you can calculate a cardiac output. Increased venous return results in increased cardiac contractility. The heart attempts to equalize volume returned. So whenever more fluid is returned, the heart's going to pump harder and it's going to pump faster to expel that fluid, because as we remember, if you have an increased amount of fluid returned to the heart or stored near the heart and it's not able to get that fluid out, that fluid's got to go somewhere. So it's going to either back up into your legs, your arms, which would be a sign of right-sided heart failure, peripheral edema, or it's going to back up into your lungs whenever it's left-sided heart failure. So the heart attempts as much as it can to equalize, and it attempts to get as much blood out as is returned to the heart. That's what's kind of explained here on this next slide. A normal heart pumps the same percentage of blood returned to the right atrium. So if more blood returns, the heart pumps harder in an attempt to basically equalize that fluid change. Okay, so blood consists of plasma, red blood cells, white blood cells, and platelets. Knowing the components of blood, it's an important concept, but more knowing the purpose of blood, in my opinion, would be more beneficial. So it carries oxygen and nutrients to the tissues. It carries cellular waste products away from the tissues, fights infection, and it can also clot and control bleeding. Plasma is the watery, straw-colored fluid. It's more than half of your total blood volume. And the platelets are essential for clot formation. So whenever you're bleeding, anytime you have an injury, anytime you have any type of, basically anytime you have any type of increased coagulation need, so the coagulation process, those platelets are going to be what is going to form that clot. And there are medications we can use to decrease the platelet aggregation, so like in the form of aspirin. And there are also medications that I'm sure you've learned about and that you can also get into that will help increase, so like a TXA type medicine, something to stop bleeding. Those all act on the platelets in your blood. Okay, so arteries are away, A and A. Arteries take blood away. Veins transport blood back to the heart. The only time this is going to be different is our pulmonary artery and pulmonary vein. They're just backwards. We remember that from A&P. So perfusion. Pretty easy, simple definition for a very important, very deep concept. Perfusion is the circulation of blood in an adequate amount to meet the cell's current needs. So the circulation of blood, that's going to be from your heart being pumped through your vessels or through your container of the fluid blood in an adequate amount to meet the cell's current needs. So it's either going to need to meet this adequate amount through rate or volume, which is going to be where our cardiac output comes back into play. The autonomic nervous system adjusts blood flow to meet the body's needs, either through a sympathetic or a parasympathetic response. The vasomotor center in the medulla oblongata helps regulate your blood pressure. And the endocrine system will also respond to changes. So aldosterone, ADH, antidiuretic hormone, falls in blood pressure will create the release of those two hormones to help stabilize, which would be, that would technically be through a negative feedback loop. Okay, so getting into a concept that you'll deal with for the rest of this chapter, which is going to be hypoperfusion, which is just shock. So insufficient circulation leads to hypoperfusion or shock. The delivery of oxygen, and what will also be is the exchange of carbon dioxide, depends on an adequate rate, an adequate volume, so there's our cardiac output, rate and volume, adequate hemoglobin levels for oxygen delivery, and also arterial oxygen saturation. So the delivery of oxygen through the blood depends on our rate and volume, which is going to be our cardiac output. We need to get enough of it, fast enough there. We need to be able to transport it in the blood through our hemoglobin to then reach an arterial oxygen saturation of an adequate amount. So pathophys of hemorrhage, very simple. Hemorrhage means bleeding. There's two types of hemorrhage that we're going to deal with here, internal and external. So external hemorrhage is going to be the obvious hemorrhaging we can see, and it's controlled by direct pressure bandaging. It can also be controlled as a last resort by a tourniquet. There are several ways to control external hemorrhage, and the difference between the two is internal hemorrhage is the same as an external hemorrhage, except you can't see it. It's internal, and there's very, very little that we can do in the field to treat an internal hemorrhage. However, there are good assessment skills and things we can understand that will help us identify a serious internal hemorrhage. Different spots in the body, whether it's in the brain, whether it's in the abdomen, the legs, the pelvis. There are different assessment skills we can learn to identify an internal hemorrhage fast enough that we can get that patient transported and get the definitive surgery that they need to repair that internal hemorrhage. So the extent and the severity is often a function of the type of wound and the vessel that's damaged. So an easy way to remember this is a very easy way to remember hemorrhage is through a laceration. So let's imagine a laceration to a capillary bed. It's going to be a very slow oozing type bleed. It's not going to be very critical in nature, and it's also going to be very easily controlled. Next to a vein. So, we've started IVs. We've seen how veins, they bleed the dark, deoxygenated blood, very slow usually. They can bleed faster depending on the extent to which the vein would be injured. But venous blood is going to be also easily controlled. Something that can become serious if a large enough amount is lost, but a venous bleed is not as severe as the next, which would be an arterial bleed. These are the ones that require, as we go back, it requires CAB. So we need to control the circulation. We need to control the hemorrhage before we move on to an airway and breathing, because an arterial bleed will absolutely have the potential to kill somebody. Arterial bleeds are going to be bright, oxygenated blood, bleeding at a very high pressure. Often they can be found if they're in a large enough artery they're bleeding from. There'll be pulsating bleeds, bleeds that are hard to control with direct pressure, especially when they're large. And also, these are the bleeds that we're going to need to possibly eventually consider a tourniquet with. Going to exsanguate. If the injury is large enough, a person can exsanguate in just a few minutes. So an injury to one of your more centrally located arteries, so your femoral artery bleeds to brachial arteries, obviously bleeds to carotid arteries. These can all result in exsanguation, which is simply broken down. Exsanguation means a person just bleeds out. They lose way too much blood, way too fast, and their blood pressure drops way too much, and no matter how much fluid you put back in them, or even how much blood they eventually get back, they've had enough tissue damage and enough oxygen loss and enough acidosis built up that they've exsanguated, they've bled out. They've gone into a form of decompensated shock that you won't be able to fix. So identifying these different types of bleeds and knowing the differences between them is very important to be able to treat a patient suffering from an external hemorrhage. Okay, so the next is going to be an internal hemorrhage. It can appear in any area. Non-traumatic internal hemorrhage usually is going to be a GI bleed, an ectopic pregnancy complication, or an aneurysm. So different ways of identifying those obviously comes with assessment skills, but GI bleeding, they're going to have that dark coffee ground emesis, or they're going to have blood in their stool. They're usually going to be able to tell you very specifically, and also assessment signs of seeing it, smelling it. GI bleeds are going to be identified that way. Where the GI bleed is at can be identified by the color and the consistency of whatever is coming out of them. So if they're having problems and it's bright red blood and it's in their stool, chances are it's going to be a lower GI bleed, and that could be very serious. A ruptured ectopic pregnancy will accompany a lot of bleeding internally, something that that they're going to need surgery for. And then obviously ruptured aneurysms. If you have an artery that has a weakening in it to the point where it ruptures, especially an abdominal aortic aneurysm, it's going to be extremely time sensitive and they're going to need surgery pretty quick. So like we were saying, going back earlier to internal hemorrhage, this isn't something we're going to be able to fix in the field. You can't apply direct pressure and stop an internal hemorrhage. What we're going to need to be able to develop as far as an internal hemorrhage goes is being able to identify it. So we're talking about, with a lot of these will come pain. We're going to start seeing early signs of shock. So we're going to start seeing tachycardia, pallor in their skin, sweating, anxiety, agitation, increased respiratory rate and depth. All these things are going to start telling us, okay, you know, we're going to need to start considering internal hemorrhage. So we're going to palpate. We're going to ask them questions. They're going to go, you know, they're going to be able to lead you in a good enough assessment to where their pain is, where this bleeding could be, and then you identifying that they have these early signs of shock and that they need rapid transport to a facility to be treated for that. So right here we have be alert to the early development of shock. So tachycardia, tachypnea, pallid skin, starting to sweat. They're becoming anxious. They're becoming agitated. These are gonna clue us into early signs of shock. So obviously, you lose enough blood, you're not going to be able to stay alive. The body cannot tolerate more than a 20% blood loss. So typically, you'll start seeing vital sign changes with just a little bit over a liter, depending on the age and depending on the health of the patient. 1 liter of blood might affect people differently. It's more important to know, one concept that's more important to know in this chapter isn't necessarily figuring out how much blood they've lost. It's figuring out if the amount of blood they have lost is leading to early signs of shock. If you get on something on scene and there's blood all over the ground and the person's acting okay and they're standing there talking to you, yeah, I mean, it's still, obviously it's important to identify that there's been a significant hemorrhage, but it's more important to have the assessment skills to know that they've lost blood, but be able to assess your patient, because one person loses a liter of blood, they could be acting fine. One person could lose a liter of blood, and they could be going into early signs of shock. It is important, don't get me wrong, it is important to understand, okay, I think that they might have lost a liter, they might have lost 500 mils, they might have lost 1,500 mils, but it's more important to identify and be very, very sound at understanding the concepts of hypoperfusion and compensated hypoperfusion and decompensated hypoperfusion. So you have a significant mechanism of injury, so you have a significant laceration, you have a gunshot wound, you have an arterial bleed, a poor general appearance, so they're not acting the way they should be for someone who just sustained a significant mechanism of injury. That tells you that they have an altered level of consciousness and that they're in early signs of shock. A significant amount of blood loss, rapid, uncontrolled blood loss. These are all things that are going to clue us in that it is a significant hemorrhage. So the physiologic response to hemorrhage, like we talked about earlier, bleeding from an artery is bright red. It will spurt with the pulse, especially when it's damage to one of your more centrally located arteries. Blood from an open vein is darker. It flows steadily. We've all seen it fill the flash chambers of our IVs. And then capillary vessels, it just oozes. Venous capillary bleeding is more likely to clot than arterial bleeding. Bleeding tends to stop within 10 minutes. That's also dependent upon health factors of the patient, whether they're on blood thinners. Someone who has a blown IV, or someone who has pulled an IV out, and someone that's a blood thinning patient, or a patient on blood thinners, excuse me, they might not stop bleeding for 30 minutes. But it is more likely to clot than an arterial bleed. So right here we're talking about the physiologic response to blood clotting. So you're going to have initial vasoconstriction, which is your body's attempt in a way to shunt blood and to stop the bleeding. You're going to have platelet aggregation, and then you're going to have fibrin formation. These are all responses to hemorrhage, and These are all feedback loops from your body attempting to stop unnecessary hemorrhaging. Hemophilia, it's a condition where one or more of the blood's clotting factors are missing. Hemophiliacs, obviously we've kind of heard this before, but any external hemorrhaging or internal hemorrhaging for that matter, all injuries are potentially serious because they lack these clotting factors, one of them or all of them. They lack these clotting factors and they're unable to stop the blood. So platelet aggregation is inhibited. Okay, so we have a patient who they're unable to produce platelets, therefore they're unable to clot. Fibrin is the essential protein that comes about with the plating aggregations, with the clotting factor. So they're unable to produce that, therefore they're unable to stop bleeding on their own. And that turns a small forearm laceration into a pretty significant bleed because they're not able to control that bleeding on their own. The trauma triad of death. This sounds pretty bad, but this is basically just going back to the feedback loops we've talked about, or that you've talked about in your pathophysiology section. So it's a combination of three things. It's a combination of hypothermia, coagulopathy, and acidosis. I might be saying coagulopathy wrong, but you know what I'm talking about. What it is it's the disruption of the body's ability to clot. It can lead to further hemorrhage, and then hypothermia, so the patient's losing body heat. And these things, the important thing to understand about these things is that they all play on each other. When one gets worse, the next gets worse, the next gets worse, and it's just it's a feedback loop. It's a circle that won't stop. It's on page 1587 of our books. I think it's pretty important to understand. I'm just going to read some of it to you. The trauma triad of death is a combination of hypothermia, coagulopathy, and acidosis that significantly increase mortality in trauma patients. These three conditions work to increase one another in a positive feedback loop, rapidly worsening the patient's condition. Feedback loop, what we were just talking about. Basically, it snowballs, is an easy way to say it. Even mild hypothermia can begin to inhibit the chemical reactions involved in the clotting process. So the way that hypothermia affects this feedback loop is it inhibits the chemical reaction involved in clotting. What we were just talking about, coagulopathy is the disruption of the body's ability to clot, and it can lead to further hemorrhaging, leading to increased hypoperfusion, so leading down that road of shock. So hypothermia leads us into coagulopathy, into our ability to no longer be able to stop our bleed, which is now leading us in further to hypoperfusion. This hypoperfusion causes the cells to use anaerobic metabolism, so very, very insufficient way of metabolizing the body's cells, and it releases additional acetic compounds into the blood. This acidosis reduces myocardial performance, further reducing oxygen delivery and body metabolism, leading to increased hypothermia. So we're right back to hypothermia again. So if hypothermia goes untreated in a trauma patient, it leads to the body's ability to no longer be able to clot. So if we're no longer able to clot in a trauma patient, we're going to continue to progress into decompensated shock. As we continue to progress into decompensated shock, we're no longer able to perform metabolism through an aerobic fashion. We're no longer able to use oxygen sufficiently in metabolism. We're starting to now resort to anaerobic metabolism, which is going to lead to acidosis. Okay, and then the acidosis feeds right back into the hypothermia, and it's just a vicious cycle. That's basically what this trauma triad is trying to get at. And we'll notice on our National Registry skill sheets and on a lot of the basic ones that you all had to do is bleeding and shock management. So, after we get done with our BSI and all that, we stop external hemorrhaging through whatever means we have to, whether it's direct pressure, dressing, or eventually a tourniquet. And then we're starting to get into shock management. So we're covering that patient up and keeping them warm. rapid transport, providing high flow O2. This is the reason why, is this trauma triad of death. If one of these things go untreated, they will just lead on to the next. This is why we keep patients warm. This is why we deliver high flow O2. It's because of this trauma triad of death. And the last thing I'll say on this, I know I've hit it a lot. If this loop continues uninterrupted, the rapidly worsening shock will lead to death of the trauma patient. Thus, paramedics must seek to identify the condition of hypothermia, coagulopathy, and acidosis in the setting of trauma and intervene where possible. This sign may be subtle and easy to overlook, but this is something that we need to treat very seriously. Like I said, it's worth reading on page 1587 of our books. And it plays well into the shock, which we're going to go into next. So this is extremely important. The reason that this is extremely important is because this is what kills people. Hypoperfusion is what leads to death. No matter how you may get to that point, knowing and understanding and having a firm grasp on what shock is, how shock develops and worsens, and how to intervene and treat shock is very important. Okay, so it can result from many conditions, as we already know: bleeding, which we're talking about now, respiratory failure, acute allergic reactions like anaphylaxis, and an overwhelming infection, which would be a sign of sepsis. So you're going to either have respiratory failure, so we're going to not be breathing, not be able to exchange oxygen, or no longer have the ability to transport oxygen, such as in CO poisoning. We're going to have pump failure, so we're going to have heart failure, tamponade, tension pneumo, that's going to lead into a hypoperfusive state from a lower blood pressure, from a decreased preload. Poor vessel function, so our container is going to fail. This is what we're kind of talking about today, along with fluid volume, but poor vessel function, so the blood is no longer able to circulate because the vessels are basically dilated to a point where they're not able to move blood in a sufficient enough manner. That's ultimately what sepsis and distributive shock is. Or a low fluid volume, hypovolemic shock, so hemorrhagic, non-hemorrhagic shock such as dehydration and third space fluid loss, which is extremely prevalent in burn patients. So hypovolemic shock, it's the shock from an inadequate volume of blood. It can be lost as blood, plasma, or as an electrolyte solution. Hemorrhagic shock is often due to blunting or penetrating injuries, gunshots, car wrecks, long bone or pelvic fractures. Your femur in your pelvis holds a lot of blood actually inside the bone, and it's also able to conceal a very large amount of blood in the spaces of your leg and your pelvis. Vascular injuries, multi-system injury. So this could be bleeding from multiple spots. You could have a car wreck, ejection patient that has a femoral artery bleed and is also bleeding in his abdomen, or has a liver laceration, multi-system injuries. And then a high incidence of exsanguation. So exsanguations are a complete loss of enough volume. We just talked about volume of blood, from the heart. The thoracic and the abdominal systems are able to conceal large amounts of blood inside of them, so an internal bleed can go a long time without being noticed. And it can also, when injured externally, you can lose a lot of blood. Your venous system or your liver actually holds a very large amount of blood, and liver lacerations, which are pretty common in more high-speed vehicle accidents. There's a high incidence of an exsanguation there as well. So hypovolemic shock is caused by hemorrhagic trauma, and it's classified into 4 classes. So class 1 and 2 is compensated. We can still intervene in classes 1 and 2 of compensated shock. Class 3 is going to be decompensated shock, and class 4 is irreversible shock. I would highly suggest getting to know this chart. This chart is very important, not only for you as future paramedics to understand recognizing shock, but let's be honest, this is extremely important for your national registry as well. There are different times when it's very important to understand I've got poor capillary refill, respiratory rate of 20 to 24. The patient's acting kind of anxious, and their skin's cool and moist. They're tachycardic. These are signs of class 2 shock. I mean, it's important to know the differences between 1 and 2, 3, and then 4. I mean, it's knowing that a pulse pressure is narrow, and okay, now it's a little more narrow. Now it's very narrow. Knowing that the pulse pressure will narrow as shock becomes worse. Knowing that the mentation will change as shock becomes worse. They'll go from nothing to kind of anxious to whenever they start to get to class 4, decompensated, and then irreversible, they're confused, they're lethargic. Skin changes as it goes down this path. Knowing this chart and knowing the signs and symptoms of class 1 and class 2 compensated shock to decompensated class 3 and irreversible class 4, it's very important. And in your book, it's going to be on page 1589. And then that leads to the next chart, which is going to be compensated versus decompensated shock. So mental status, tachycardia, pulse pressures, tachypnea, thirst. Thirst is one that kind of takes you a while to kind of understand, but thirst, knowing that they're compensating, and the big one is going to be mentation. An agitated, anxious patient versus a unresponsive, basically an unresponsive patient, a decreased GCS patient. Those are going to be very important to learn. So hemorrhagic shock, the initial stage is characterized by a low circulating blood volume, minimal signs of hypoperfusion. So everything seems to be fine. As it begins to go down this progression, they become more tachycardic. That's the negative feedback that the negative feedback loop, that the body is trying to produce in order to compensate. So it's either got to increase the rate or it's got to increase the volume to increase the cardiac output. So the way it does that is if you're losing blood, it can't increase the volume, so it's going to increase the rate. Your hypotension, as you lose more fluid, your blood pressure is going to drop. And also as you lose more fluid and as your blood pressure drops, you have signs of poor tissue perfusion, whether it's to the brain, so your mentation changes, or whether it's the more obvious sign, which is to your skin. Knowing these signs and knowing how to differentiate between compensated and decompensated shock is very important. Okay, so kind of going into the scene size up, got to make sure the scene's safe. Understanding the significance of the mechanism of injury is extremely important. Knowing, always keeping in mind that internal bleeding may also be caused by illnesses. You could have a person that's got a aneurysm that gets in a little car wreck. Well, that could be significant enough to be able to kill them. It's important for you to understand that a good assessment and a high index of suspicion is very important to be able to cover any possible injury to a patient. So your primary survey, mental status, using the AFPU scale. If you're unfamiliar with the AFPU scale, real quick: alert, verbal, painful, or unresponsive. So if they look at you as you walk up to them, we'll picture a patient with a gunshot wound. You walk up to a patient with a gunshot wound and they're looking at you, they're kind of freaking out a little bit, which would be a pretty normal response, in my opinion, to a gunshot. Well, then they're alert. But as you go down the scale, they're verbal. They don't really acknowledge you as you walk into the room. They just seem kind of out of it. They might have lost a lot of blood, but they're able to talk to you once you start kind of talking to them. That's going to be verbal. Painful, you think that they're dead and unresponsive. You go up to them to elicit a painful response by a sternal rub or something like that, and they kind of pull away from you. Their GCS is more in that 5 to 6 range, and then unresponsive GCS of 3. They've either irreversible shock, they've decompensated to the point where they're unable to talk to you, or they're in cardiac arrest. You have to locate and manage immediate life threats and any major external hemorrhage. Those are kind of saying the same thing. So ABCs, or in this case, CAB. A patient with an internal hemorrhage needs rapid transport. Like we've talked about 5 or 6 times now, it seems like we're not able to treat those internal hemorrhages necessarily in the field. We're definitely not able to stop them. So identifying by learning our signs, going back to shock, learning our early and late signs of shock will help us identify an internal hemorrhage, and we can get them the only thing that's going to fix them, which is laying down in front of a surgeon. Minor external hemorrhaging, they got some scrapes, or they have flesh wounds, or you don't, through your own clinical impression, you don't think it's going to be a serious enough hemorrhage. Document it. Moving on to treat our life threats. Moving on to our history, dizziness, syncope, current meds that may thin blood. One thing about these are especially important in our older patients. So you have older patients who fall more frequently, older patients who might fall and not be able to get to some lines of communication to get EMS there faster, and they might be on blood thinners. These are our patients that getting a solid history on is very important, because they could fall and have very, very minimal signs of hemorrhaging, especially head injuries where they may be bleeding, and a healthy 20, 30-year-old patient that's not on blood thinners, it's going to be able to clot. They're going to have more time to be able to be seen in a hospital versus an older patient who might be on blood thinners, where that injury is much more significant because their clotting factors are reduced, and they're no longer able to stop that bleeding themselves. So getting a solid history is still very important in any patient, but especially in our older patients who could be on blood thinners. Performing the full body scan, just so you don't miss something. The last thing you want to do is get called on a patient. Going back, it's real easy to resort to the gunshot patient. To go on a gunshot patient who you find 3 or 4 gunshots to the arms and to the legs, and everything's fine, but you forget to check their pelvis. Well, they could have a gunshot to the pelvis, and they're just not able to tell you. They don't know. Their adrenaline was running to a point where it's masked itself, and they don't have the ability to really tell you about it. And the only way you're going to be able to identify it, especially on our going back to our AVPU scale, on our painful and unresponsive patients, is through a thorough assessment, getting the patient trauma naked, investigating possible bleeding, doing a quick scan, initially on scene, loading them and going. You have to be able to figure out a bleed, because it's one thing that, obviously along with the airway and breathing, it's one thing that can kill a patient very fast. Internal hemorrhaging, hematoma, melena, hematuria, and pain and tenderness and guarding. They might have Cohen's sign, which is going to be bruising around the umbilicus. They might have Gray-Turner sign, which is going to be flank bruising. That's going to be different signs of internal hemorrhaging when they tell you either they did sustain an external force, so they got hit with a bat, they got ejected from a car, they got ran over, they got beat up, and you look and you see all that bruising. That's going to be pretty obvious. But if you've had a patient who has a bleed in his stomach, or he has a bleed in his kidneys, or he has any type of internal bleeding, you're also going to be able to expose that patient, and you may see the internal bleeding there. They're going to have generalized pain, guarding, tenderness. It's going to be warm. It's going to be rigid whenever you palpate the area. So these are types of internal hemorrhage. Still going to look at all of our anatomic regions. Still going to rule out other injuries as well. That's always important in our secondary assessment. And then reassessing every 5 minutes in or out on any severe hemorrhage, any severe patient. And that's hard to remember, but it is important, because that's how we're going to establish trends. That's how you're going to establish, like we talked about earlier, a narrow pulse pressure, increasing tachycardia, mental status changes. Those are through reassessment. If you assess somebody on scene and they're okay, they have, let's say that they have a significant mechanism of injury. You assess them on scene and they're fine. And then in some cases, you have a 20, 30-minute transport to the hospital and you haven't reassessed, especially every 5 minutes in a critical. Stuff can go bad pretty quick, especially, this is especially true in pediatric patients who will compensate very well for a very long amount of time until they decompensate, and then they decompensate instantly. So performing our 5-minute reassessments, maintaining that high index of suspicion, and continuing to look at the patient for signs and symptoms of decreasing shock signs is very important. So now we're going to talk about treating bleeds. Signs of hypoperfusion, signs of shock, aggressive management en route, that's stopping our bleeds, providing fluid resuscitation, fluid boluses, trying to keep the patient calm. A big one's keeping them on oxygen, and also remembering back to our trauma triad of death, keeping the patient warm, especially if they've lost a large amount of blood, because hypothermia leads to an increased inability to produce clotting factors for bleeding, which will lead to acidosis, which will lead to more hypothermia. We remember the trauma triad of death from earlier. Hemorrhaging from the nose. Some people might think this is minor, and I understand that because, hey, a nosebleed isn't exactly the thing we all signed up for, but we also have to remember that in some patients, it might be a blood pressure issue, and we remember back to what we were talking about, patients on blood thinners. Some of these bleeds can turn into very serious bleeds, so we have to be able to treat these bleeds like any other bleed, any other hemorrhage, and be able to identify that it is serious. Also, talking about trauma, skull fractures. So if you have a caribiform plate fracture, for example, you're going to have CSF and bleeding coming out of the nose. But if you have a basilar skull fracture, you're going to have CSF and bleeding coming out of the ears. Is it important to differentiate a basilar skull fracture from a caribiform plate fracture? Probably not. But is it very serious to identify CSF bleeding from these locations? Absolutely. There are multiple protocols around the state that indicate a skull fracture of any type as a priority 1, trauma 1 patient. And if we come up on a patient and we just touch their head and we move on and we don't do a thorough assessment, we might not feel any indentation or any skull fracture. But if we check their nose and we check their ears and we see that we have that cerebrospinal fluid, we'll know, okay, well, they have a skull fracture. I'm not able to feel it, and I'm not able to really even see it. But I can tell you that CSF coming from a patient's nose is not normal, and that does indicate a caribiform plate fracture, and that CSF coming from a patient's ears indicates a basilar skull fracture, both of which will absolutely kill a patient. So it is very important to know signs and symptoms of different types of bleeding. Apply cold compress to the tip of the nose. Place rolled gauze under the upper lip. There's an artery that goes right underneath your nose, behind your lip, on top of your teeth. There's actually an artery there. I can't remember off the top of my head what that artery was called, but if you do apply cold to that artery, it will constrict and it will slow the bleeding coming from a person's nose. Pressure or even applying cold to that area. And then you're going to transport these patients. You have to check their blood pressure 5 minutes. Hemorrhaging from other areas, so we're going to control through direct pressure. Remember, we're going to apply direct pressure with a gloved hand. Pack large gaping wounds with sterile dressing. Keep the patient warm and in the appropriate position, which is going to be supine. And transport condition should indicate mode of transport, the patient's condition, excuse me. So when we're talking about the use of direct pressure, this is one skill that in the field especially, if you have a patient that has had a significant loss of blood or sustained a significant enough injury, applying that direct pressure and applying large gaping wounds with sterile dressing, packing those wounds. It might look extremely painful, but it's one thing that through experience you'll understand that these are the times that you have to be extremely aggressive. You have to be extremely aggressive about certain things in EMS, and external hemorrhaging, especially arterial external hemorrhaging, is one time in a medic's treatment regimen that they have to be extremely aggressive. We'll talk about that more a little bit later as the chapter goes on. Tourniquets. It's useful for severe hemorrhaging from an extremity injury below the axilla or groin, and there's many options available, as you see here. Tourniquets are a last resort, but just because they're a last resort, that doesn't mean they shouldn't be used. If you come upon a patient and you've applied that direct pressure, you've applied the pressure dressing, you've applied more pressure dressing, you could have possibly have elevated. There's nothing you're able to do to stop that external bleed. Well, then you have to apply a tourniquet. You have to stop that bleed. There is no option. Not stopping a patient's arterial bleed will lead to a dead patient. Applying a tourniquet is something that a lot of people feel hesitant about doing, but it's something that you have to learn to do and to be proficient in applying it and knowing when to apply it, and also remembering when you applied it, how long it's been applied. If a commercial tourniquet's not available, you can apply a triangular bandage in a stick or rod. I don't know how many apparatuses carry a big old tree stick. That's probably not in a lot of people's budget. But one good thing that does work is a blood pressure cuff. I'll tell you that. You can apply a blood pressure cuff and you can continue to charge it. I've seen belts applied before. But what it's important to remember is stopping the bleed any way you can. A junctional tourniquet. This is kind of a new one for me. It's used when hemorrhage is inguinal or axillary. A belt system holds the device in place, and a pump inflates a compression device to put pressure on the deep vessels. So this is trying to stop an axillary bleed, possibly a pelvic bleed or a femoral bleed. Do not apply it directly over a joint. Use the widest bandage you can. I don't know how many of you have ever used one of these, but I'm sure there would be in-services and training on them. A splint. Broken bones can lacerate tissue, causing bleeding. They can also, one thing bones can do is they can not really allow a clot to heal. So if you have a bone that's constantly moving, it might not necessarily be lacerating tissue, but it is continuously busting up those clots that form. So it sits still long enough and you're bouncing down the road in an ambulance and it's bouncing around as well. It's not going to really allow clotting. You need to be able to cover the bleed, stop the bleed, absolutely first of all. And then as you go from there, you want to splint the area affected. You want to make it as immobilized as possible to keep from disrupting the clotting process. And just another tool in the toolbox would be an air splint. These work well. Just you got to remember whenever you apply splints, you have to always continuously, before and after, check PMS, which is the pulse, movement, and sensation in the distal extremity. That's very important to remember with splints. Traction splints for femur fractures. This seems very painful, but it seems like most patients that require a traction splint from a femur fracture, as soon as the traction splint's locked into place, they greatly appreciate it because it reduces a lot of the pain. A hemostatic agent. A lot of these came from the military, and these work well, especially for gunshot wounds. It's used to control a severe hemorrhage when a tourniquet cannot be placed. So let's think about times when a tourniquet can't be placed. You have a femoral injury. You have someone who has a laceration to their inner thigh. You have someone who has significant bleeding coming from the abdomen or the chest. You're not really able to put a tourniquet there coming from someone's axillary region, mid-axillary region, excuse me, so from somebody's armpit. You're not really able to control bleeding there with a tourniquet. Tourniquets are for extremity injuries. This is for more centrally located injuries. It adheres to a damaged tissue and it dehydrates the blood, or it undergoes a reaction to cause the blood to clot. How it works is you'll tear it out of these packs and then you will literally just pack it into the wound. There are several YouTube videos available that you can look these up. There's a lot of surgeons that have used these in the military, and it's not something to be shy with. This is something that whenever you do need to use it, it's going to be a very critical situation where you have to stop a bleed, and you will pack it as far down into the wound as you can. It's just a cloth-like material, and you just continue packing it and continue packing it. And it will eventually assist you in controlling a severe hemorrhage. It's lightweight and easy to store. It's really small. It comes in a little, maybe a little 3x3 inch little container. It conforms to the wound itself. High pressure. It's very effective on arterial bleeds. It causes little or no damage to the tissue. The physicians in the hospital, it's easy for them to remove, and it does not spread into the rest of the system. It's a locally applied agent that helps you keep people from bleeding out. The complications is the powder. It can form an emboli through open vasculature, and the powder used, it is a foreign substance. I mean, at the end of the day, it's not natural to the body, so there are complications, but I think the complications are far outgained by the potential benefit of stopping a patient from bleeding out of an arterial bleed. It's particularly helpful in junctional areas. It absorbs liquid from the blood and it helps to concentrate clotting factors. When used with hemostatic agents, it can chemically accelerate the clotting process. So now we're going to talk about internal hemorrhage. So we're once again, for the 100th time, I know, we're not really able to treat or to reverse the internal hemorrhage itself, but we can focus on several other things. We can focus on identification of it through a solid assessment. We can focus on rapid transport to get them in front of a surgeon who knows a lot more than we do. And we can also focus on the treatment of shock. We can treat the patient's oxygen by giving them high flow O2. We can keep the patient warm. We can try our best to minimize and slow down that trauma triad of death we talked about earlier, the acidosis, the decreased clotting, and the hypothermia. And we can also, as paramedics, you're able to treat blood pressure issues through fluid resuscitation, keeping the patient flat, keeping the patient calm, trying to slow that heart rate, basically trying to maximize the efficiency of the cardiac output that they do still have available. But eventual surgery will be needed to stop the bleed. So the process is given nothing by mouth. We talked earlier about one of the signs of shock is going to be increased thirst. As much as you want to help that patient out, man, and you want to give them something by mouth, don't. Chances are good they're just going to throw it back up anyway. Establish 2 large bore IVs. It doesn't say large bore, but trust me, the more fluid you can get into some of these patients, the better, especially when we're talking about burn patients, which will be another chapter, but it does present the same as a lot of signs and symptoms of shock. Pain medication's okay. Pain medications, you carry pain medication for a reason. The one thing we got to be careful about with pain medication, obviously, is our blood pressures. We have a patient who has large amount of internal hemorrhaging. They're really hurting, man. You know, they're really wanting some blood pressure, or excuse me, they really want some pain medication, but their blood pressure's in the tank. Well, I would rather have a patient in pain with a low normotensive blood pressure than I would a patient that's feeling pretty good, but they're about to die. So we have to monitor that blood pressure with our pain medication. Immediate rapid transport. That's why the the vehicle we work in's got wheels on it. That's what we're there to do, is to identify people's injuries, identify the severity of the injuries, do what we can to help keep that patient alive, but ultimately provide immediate rapid transport to a hospital and try to establish our trends en route. So the management of hemorrhagic shock. This is a big skill to learn. Obviously, going back earlier, we talked about CAB. Our priorities are circulation, so stopping our bleeding. A, our airway, and then B, our breathing. Treatment, stop the major bleeding, very important. Once we get that bleeding stopped and controlled, we can move on to our A, which is going to be our airway. Ensure that the airway is open, calm the patient and keep supine, nothing by mouth. Once we've stopped the bleed, controlled the airway and the breathing, we've got them on high flow O2 because it's possible signs of hemorrhagic shock. We have to give them the O2. As we've laid the patient flat, we've covered them up to keep them warm, nothing by mouth. So now we're going into our secondary assessment and treatment. We're going to splint and immobilize our injuries. We've been preventing and managing shock this whole time. And now's the time, after we've treated all of our primary assessment, after we've got all of our basic skills done, the same things that we've been doing all the way through basic school and the same things now that we've been doing all the way through medic school, we have to start basic. Once we've got all of our basic things done, then we can move on to our IVs. Then we can move on to our fluid resuscitation. One thing that's extremely important, and one thing that I had to really focus on, was everybody starts in the same place. As amazing as it sounds, even physicians start in the same place. Everybody starts with a thorough, basic primary assessment, stopping the major bleeding, ensuring an open airway, and ensuring adequate respiratory effort by our patient. Ensuring that all of these things are in line first is what we have to do before we can establish our IVs, before we can move on to fluid resuscitation and different types of medications to increase the clotting factor in patients. We have to start basic. Then we're going to monitor the ECG for dysrhythmias, so we're starting to look at tachycardia, state of consciousness, just part of our continuous reassessment. Is it increasing? Is it decreasing? Is it staying the same? Is the pulse increasing, decreasing? And our blood pressures. Obviously, our blood pressure is extremely important in the management of hemorrhagic shock. Okay, so this is going to be the last slide of the slideshow. So just some quick notes to go over, just on a real basic level. So the cardiovascular system, respiratory systems, maintain our perfusion of circulation of blood. We need to have an adequate amount of fluid pumping from an adequate pump through adequate piping or an adequate container. It's got to have a good enough hemoglobin count to it to be able to actually transport that oxygen. Being able to identify a serious external hemorrhage, and also, which can be even trickier, a serious internal hemorrhage is extremely important. Knowing that hypoperfusion or shock occurs when the level of tissue perfusion decreases below normal. Also knowing how to be able to identify that decrease or identify that continuum of shock in patients as they are decreasing. We remember back to page 1589, table 30-2 and 30-3 are two ways of being able to identify a compensated patient or a decompensated and eventual irreversible patient. So being able to do that. Absolutely remembering that as with any patient, airway and ventilatory support take top priority when treating a patient with suspected shock. But we need to remember when that is a shock that comes from a hemorrhagic or an external hemorrhage, we have to put our circulation first. So we have to stop the bleeding first, and then move on to monitoring our airway and our breathing. Methods for controlling serious external hemorrhage include first, gloved hand direct pressure, pressure dressings and or splints, and then tourniquets. But one thing that is kind of nice to remember is that most cases of external hemorrhage, it can be controlled with direct pressure to a bleeding site. But just like shock moves down a continuum, so does bleeding control. So If direct pressure fails to immediately stop the hemorrhage, we have another way of fixing it, to an extremity at least, is to apply a tourniquet to a proximal site of the bleed. If a commercial tourniquet isn't available, we remember back to the big stick that got wrapped up. You got to figure out a way. You got to adapt and overcome and figure out a way to stop that external hemorrhage. And also, we have our hemostatic dressings, our combat gauze is what a lot of people call it. Managing a patient with an internal hemorrhage focuses on treatment of shock, minimizing movement, and rapid transport. Also identifying that this is a significant internal bleed. These are significant clinical presentations and significant vital signs that indicate a serious bleed. And last but not least, be alert and search. Continuously search for early signs of shock. The last thing we want to have happen is complacency or think that this patient's okay because we didn't do a thorough assessment. We didn't start at a thorough basic level and check our things going down that road. So the end of this chapter ends on what's going to be page 1607. There's a lot of important terms in there. The assessment in action is a pretty good one. It kind of gives you a way to identify kind of a scenario to work on. And then our vital vocabulary there on the side for any confusion that might have came place from some different types of words. A lot of good information there as well. So that will conclude the chapter on bleeding and hemorrhagic shock treatment.